Usually when we talk about a medical diagnosis, there's this expectation of precision.
Oh, absolutely. Like
Yeah.
it's engineering or something.
Right. Like you break your arm, the x-ray shows that jagged white line, and the doctor just points to it. They say, there it is, there's the problem.
Yeah, it's binary. Which honestly is incredibly comforting to a patient. We desperately want our biology to just be visible.
Right.
We want it neatly categorized into normal and abnormal or just, working or broken.
But then you step into the world of immunology, and specifically the realm of allergies and immune hyperreactions.
Yeah, and suddenly that beautiful, clear X-ray machine is totally useless.
It really is. We
Yeah.
are looking at a diagnostic landscape that is just astonishingly murky because, well, the enemy isn't always some invading bacteria.
Right, it's not a foreign virus causing obvious direct destruction.
In these cases, the enemy is actually the very system designed to keep you safe.
Exactly. I mean, our immune system is this miraculous, highly calibrated defense network. It took millions of years to evolve.
But sometimes that meticulous calibration just fails.
It does. The system mounts this exaggerated, entirely inappropriate, and honestly sometimes catastrophic response. And it targets foreign substances that are otherwise completely harmless.
Things like pollen or a peanut or an antibiotic.
Yeah. And the end result of that overreaction isn't protection for the body. It's severe inflammation and really profound tissue damage.
Okay, let's unpack this. Why does our body suddenly treat a peanut or a speck of pollen like it's a deadly pathogen?
Well, answering that is the exact mission of our deep dive today.
We're so glad you're sitting at the table with us because we are unpacking the mechanical, molecular roots of these reactions.
And we're working from an incredible set of source materials for you today.
We really are. We have these comprehensive university-level lecture notes, detailed schematics, and clinical presentation slides.
Yeah, they're from University Immunology professor Adriana S. Coutinho. She's at the Federal University of Rio Grande do Sul in Brazil.
Her work meticulously breaks down what scientists call hypersensitivity reactions.
Right. And we're going to use her framework for a strict, sequential 5-module progression.
We're going to trace the cellular mechanisms, the underlying genetics, the environmental triggers, and the clinical realities of all 4 distinct types.
Professor Coutinho's material is rigorous. I mean, it really demands that we leave our assumptions at the door.
Because when most people hear the word allergy, they're picturing a very specific thing, right?
Yeah, they picture what immunologists classify as a type I hypersensitivity.
Right.
So let's officially announce our first module. Module 1, type I hypersensitivity, also known as immediate hypersensitivity.
Okay, module 1. But to understand why someone's throat closes when they eat a shrimp, we have to start way before that meal ever takes place.
We do. We have to look at a covert, behind-the-scenes event called the sensitization phase.
That's the thing that always trips people up. You aren't actually born allergic to a specific thing, are you?
No, you are not. A person is never allergic upon their very first contact with a potential allergen.
So you don't typically have a severe allergic reaction the first time you ever encounter a substance.
Exactly. Sensitization is this quiet priming of the immune system. Let's trace the biochemical cascade of that very first exposure.
Okay, let's do it.
Imagine a microscopic protein from, say, a ragweed pollen grain enters your body. It usually lands on a mucosal surface, like the lining of your respiratory tract.
And prowling that tissue are these sentinel cells, right? The antigen-presenting cells, or APCs.
Right. They act like a neighborhood watch. They're just patrolling the area looking for absolutely anything that doesn't belong.
So the APC bumps into the ragweed protein. What happens?
It physically engulfs it. It just swallows it and breaks it down using its internal enzymes.
It fragments the allergen into tiny little peptide pieces?
Yes, and then it takes one of those fragments and displays it on its outer surface. It's almost like holding up a mugshot.
I love that visual. Then what?
The APC then leaves the tissue, travels through the lymphatic vessels, and enters a local lymph node.
Because it needs to show this mugshot to a specific cell, right?
Exactly. A highly specialized regulatory cell called the T helper 2 cell, or Th2 cell.
So the APC hands over the evidence. What does the Th2 cell do with it?
Well, if this is a harmless piece of pollen, shouldn't the Th2 cell just shrug it off?
Yeah, in a normal person, wouldn't it just ignore it?
In a non-allergic individual, yes. The interaction might lead to a quiet, tolerogenic response. Basically an agreement to just ignore it.
But in a susceptible individual?
Right. In a susceptible individual, this interaction is the spark that lights the powder keg. The Th2 cell becomes highly activated.
It misinterprets this harmless protein as a dangerous invader.
Yeah, perhaps confusing its molecular shape for a parasite. Once activated, these Th2 cells begin rapidly secreting chemical messengers.
These are cytokines, right?
Yes. And the critical ones here are interleukin-4 or IL-4 and interleukin-13.
So the Th2 cell starts ringing the alarm bell by flooding the local environment with IL-4 and IL-13. Who is listening to that specific alarm?
The B cells. B cells are the antibody factories of our humoral immune system.
And normally, upon first encountering a brand new antigen, B cells do what?
They are programmed to produce an antibody called immunoglobulin M, or IgM.
IgM is a massive pentameric molecule, right?
Yeah, it serves as an excellent generalized first responder. But when a B cell is suddenly bathed in high concentrations of IL-4 and IL-13 from that panic Th2 cell,
It receives a forceful chemical instruction.
exactly, it gets the signal to undergo a dramatic process called class switching.
I want to pause on class switching because it sounds like the B cell just, I don't know, grabs a different tool off the shelf.
It's much deeper than that.
It's literally changing its own genetic machinery, isn't it?
It is a permanent structural change. The B cell stops producing the standard IgM, physically rearranges its own DNA, and begins churning out a highly specialized antibody.
And in this context, a highly problematic one.
Very problematic. Immunoglobulin E, or IgE. And this newly minted IgE is custom-tailored to recognize that exact ragweed pollen protein.
Wow. So the body just manufactured a highly specific weapon against a harmless weed.
Yeah, it did.
But the IgE doesn't just float around aimlessly in the blood. Where does it go?
It has a very specific destination, which brings us to the core cellular players in a type I reaction.
Okay, who are the players?
Out in the connective tissues, deep in the layers of the skin, the lining of the lungs, the mucosal walls of the gut, we have cells called mast cells.
They are stationed there like local border guards.
Right. And in the bloodstream, we have circulating counterparts called basophils and eosinophils.
Do they all come from the same place?
They do. All of these cells originate from the exact same place, the bone marrow, through the process of hematopoiesis.
So what do mast cells and basophils have that makes them a magnet for this newly manufactured IgE?
They possess a highly specialized protein structure permanently embedded in their outer membrane. It's called the high-affinity Fc epsilon Ri receptor.
I think I've seen it written as Fc epsilon Ri.
Yeah, exactly. Think of this receptor as a dedicated docking station. It is designed exclusively to grab hold of the tail end, the FCC portion of an IgE antibody.
So those B cells pump out massive amounts of ragweed-specific IgE into the circulation.
And those antibodies travel through the body and permanently dock into the Fc epsilon Ri receptors on the surface of millions of mast cells.
And once they dock, they just sit there.
They just sit there. A single mast cell can be coated in hundreds of thousands of IgE antibodies.
All facing outward like microscopic radar dishes.
Right, just waiting for that specific ragweed protein to appear again. This state, the cell being fully loaded, primed, and highly reactive, is the definition of sensitization.
So the trap has been meticulously set, but the person feels absolutely nothing.
Exactly. They have no idea they're allergic yet.
Okay, so fast forward maybe a month, maybe a year. Our sensitized individual walks through a park in late August.
And they breathe in that exact same ragweed pollen.
The pollen protein enters the respiratory mucosa and bumps into those primed mast cells.
But for the mast cell to actually fire its weapons, to initiate what we call degranulation, it's not enough for the pollen to just touch a single IgE molecule, is it?
Right, there's a mechanical trigger required.
The mechanism is wonderfully elegant, but clinically devastating. It is called cross-linking.
So a single IgE molecule binding to the allergen does absolutely nothing.
Nothing at all. The mast cell remains quiet.
Okay, if I'm picturing the surface of this mast cell, it's covered in these IgE antibodies. If the allergen binds to one, it's a dud.
Yep.
It sounds like those old submarine movies where the commander and the executive officer must turn two separate keys simultaneously to launch a missile. One key won't do it.
That is a phenomenal visualization of the biochemistry at play.
So the allergen is a specialized key that physically bridges and links two adjacent IgE antibodies on the mast cell's surface, initiating the launch sequence.
Perfectly said. When one single allergen molecule is large enough, or has repeating structural motifs, it binds to two adjacent IgE antibodies at the exact same time.
And it physically pulls those two IgE molecules and their attached receptors closer together in the cell membrane.
Right. That physical pulling, that clustering of the receptors, is the launch sequence.
What actually happens inside the cell once those keys are turned? How does pulling two receptors together make a cell explode?
The clustering of the receptors alters their internal structure, which triggers a complex intracellular signaling cascade.
And what's the immediate result of that?
The immediate critical result is the opening of ion channels in the mast cell's membrane. This causes a massive rapid influx of calcium ions from the outside environment into the interior of the cell.
Because in biology, a sudden flood of calcium is like the universal go signal, right?
Exactly. It triggers the immediate explosive release of preformed granules that were stored inside the cell, the degranulation.
Let's talk about what's actually inside those granules. Professor Coitino divides the clinical symptoms into two distinct phases.
She does. There's the early phase, which happens almost instantly, and then a late phase.
For the early phase, what is the chemical payload that gets dumped into the tissue?
Well, the early phase peaks within 5 to 15, maybe up to 30 minutes after exposure. It is driven entirely by mediators that were pre-manufactured and just sitting in those granules waiting for the calcium signal.
The most famous one is histamine, right?
Of course. When histamine hits the surrounding tissue, it binds to receptors on local blood vessels, causing them to violently dilate and become highly permeable,
The vessels literally leak fluid into the tissue,
which causes the sudden localized swelling, the redness, and the severe itching.
which is why the first thing anyone reaches for is an over-the-counter antihistamine. But histamine isn't acting alone, is it?
Not at all. The granules also release heparin, which is a powerful anticoagulant.
So that keeps the blood flowing into the inflamed area.
Right. It prevents clotting from walling off the site. Then we have a barrage of potent enzymes: tryptase, cammase, carboxypeptidase, and cathepsin G.
Wow, that's an intimidating list of chemicals. If histamine handles the swelling, what are these enzymes doing to the tissue?
They act as aggressive molecular scissors. Tryptase and cammase begin rapidly degrading the local connective tissue matrix.
They're literally chewing up the microscopic scaffolding of your tissue.
Yeah, to make room for other immune cells to physically enter the area. It's a biological scorched earth tactic.
So the body is utilizing tools evolved to physically flesh out a multicellular parasitic worm, but it's deploying them against an invisible fleck of pollen.
That's exactly it. And that explains the immediate misery, the sudden sneezing fit, the rapid appearance of hives, the watery eyes.
But anyone with severe allergies, especially asthma, knows you don't just take a pill and feel perfectly fine an hour later.
Right.
The reaction drags on. Why is there a second wave?
That second wave is the late phase, kicking in 4 to 24 hours after the initial exposure. Well, the early phase was about releasing weapons already sitting in storage. The late phase is about the mast cell manufacturing entirely new weapons from scratch.
Oh, wait, it makes new ones.
Yeah. Once activated by that calcium influx, the mast cell immediately starts synthesizing lipid mediators. It actually breaks down its own cell membrane lipids to create them.
And who are the key players here?
The key players are prostaglandins, specifically PGD2, and leukotrienes like LTC4, alongside sphingosine 1-phosphate or S1P.
If we already have histamine causing swelling, why does the body spend energy manufacturing prostaglandins and leukotrienes? What do they add to the fire?
They're essentially vastly more potent, much longer-lasting versions of histamine, but they come with a terrifying addition.
What's that?
They cause profound, sustained, smooth muscle contraction. If this reaction is happening in your lungs, those leukotrienes clamp down on the smooth muscles surrounding your airways.
Oh, wow. This is why an asthma attack makes it so difficult to breathe.
Yes, the airways physically shrink, and the prolonged vascular leakage fills them with thick mucus.
But the mast cell isn't just causing local damage, right? It also acts as a dispatcher calling for massive reinforcements.
It sure does. Alongside the lipid mediators, the mast cell initiates a true cytokine and chemokine storm.
It just starts dumping signaling molecules.
Massive waves of them. IL-4, IL-5, IL-8, IL-10, IL-13, IL-16, TNF-alpha, GM-CSF, MCP-1, and MIP-1A.
Okay, we definitely don't need to memorize that alphabet soup, but let's pick out the heavy hitters. What is the net result of all those signals flooding into the bloodstream?
The net result is aggressive cellular recruitment. For instance, IL-5 is the master recruiter for eosinophils.
It calls in vast armies of these toxic cells from the bone marrow.
Exactly, and IL-8 does the same for neutrophils. This storm drags huge numbers of highly destructive inflammatory cells into the tissue.
And by the time they arrive hours later, the ragweed pollen is usually long gone.
Yeah, it is. So these frustrated cells end up dumping their toxic payloads onto healthy host tissue.
This is why chronic asthma isn't just about temporary wheezing, is it?
No. Over time, this repeated late-phase cellular attack causes permanent airway remodeling and chronic tissue damage.
I want to throw a wrench into this mechanism. I have a friend who went into a hospital for a routine CT scan.
Okay.
They injected him with an iodine contrast dye. Within 3 minutes, he was covered in full-body hives, his throat started closing, his blood pressure tanked.
A massive, immediate degranulation event.
But he had literally never had contrast dye before in his life. He couldn't have had a sensitization phase. There was no specific IgE waiting on his mast cells.
Right.
How does a type I reaction happen without the core requirement of type I?
That is a vital clinical distinction. What your friend experienced is called an Ig-independent or anaphylactoid reaction.
Anaphylactoid, so it looks the same.
The symptoms are clinically indistinguishable from a classic type I allergy
Right.
because the end result, mast cell degranulation, is identical.
The histamine and tryptase are still released.
Yes, but the trigger, bypassing the entire sensitization pathway, is entirely different.
So the submarine launched its missiles without the commanders ever turning the keys.
Precisely. Mast cells are incredibly volatile. Their membranes can be destabilized and forced to degranulate directly by certain stimuli, completely ignoring the IgE and Fc epsilon Ri receptors.
Professor Coitino's notes explicitly detail these direct triggers, right?
She does. Physical stimuli can do at extreme changes in temperature, like plunging into ice water or even intense sunlight in certain rare disorders.
Just a physical shock to the system pops the cell open.
Yeah. Then there are chemical triggers. Iodine contrast dyes are notorious for directly destabilizing mast cell membranes.
Are there any drugs that do this?
Certain heavy-hitting drugs, specifically opiates like codeine and morphine, can directly induce degranulation.
Which is why patients often get incredibly itchy when taking them, even without a true allergy.
Exactly. And finally, our own immune system has built-in backdoor triggers.
What are those?
Specific proteins from the complement cascade. The anaphylaxis toxins C3a, C4a, and C5a. They can bind to unique, separate receptors on the mast cell and command it to degranulate. No IgE required.
That is terrifying but fascinating. So we have this immensely complex system sensitization, IgE production, cross-linking, massive degranulation, and late-phase cytokine storms.
That's a great synthesis of Module 1, IgE-mediated immediate degranulation.
But it begs a massive question. Which brings us to the next module. I'll explicitly announce it. Module 2, Type I genetics, environment, and clinical applications.
Perfect.
So why do some people develop this intense Th2-skewed, IgE-heavy response to a harmless peanut or piece of pollen, while my immune system looks at the exact same peanut and completely ignores it?
If we pull back from the cellular level and look at human populations, we find that allergies are profoundly unfair, and they are not distributed equally.
There is a deep genetic component, right?
Yes. If both of your parents are highly allergic, your statistical likelihood of developing atopy, the genetic tendency to develop allergic diseases, skyrockets.
Because you inherit a genetic blueprint that heavily favors that panic Th2 pathway.
Exactly. Researchers have mapped the susceptibility to specific genetic loci. Professor Coitino highlights two major chromosomal hotspots.
What's the first one?
First is chromosome 11. This chromosome contains the gene that specifically codes for the beta chain of the Fc epsilon Ri receptor.
The docking station on the mast cell.
Right. Variations or mutations in this gene on chromosome 11 can cause a person's mast cells to express an abnormally high number of these docking stations or make the receptors bind IgE much more tightly.
So the cell becomes hypersensitive? What's the second hotspot?
The second major hotspot is on chromosome 5. This region is fascinating because it houses an entire cluster of cytokine genes packed closely together.
Which cytokines are living in that neighborhood?
The exact ones driving the allergic nightmare: IL-3, IL-4, IL-5, IL-9, IL-13, and GM-CSF.
Wow, they're all right there together.
Yep. This genetic cluster on chromosome 5 drives the B-cell class switching to IgE. It dictates the survival and aggressiveness of eosinophils, and it controls the proliferation of mast cells.
So a genetic tendency to overexpress this specific cluster guarantees a hyperactive Th2 response.
It really does. Coitino also points to the HLA system, our tissue typing complex.
Right. There's a specific haplotype mentioned.
The specific haplotype HLA-B1*1501. It's strongly and consistently linked in epidemiological studies to the development of specific severe pollen allergies.
Okay, so the genetics load the gun. But human genetics take thousands, if not millions of years to shift meaningfully across a population.
Sure.
Yet, the epidemiological data shows that 25 to 40% of populations in industrialized nations now suffer from allergic symptoms. Here's where it gets really interesting.
Yeah, that is a massive, incredibly rapid spike over just the last century. Genetics alone cannot explain that speed.
Something in our modern environment is pulling the trigger.
The explosion of allergic disease correlates almost perfectly with a few key modern developments: rapid industrialization, urbanization, widespread antibiotic use, and modern sanitation.
This paradox that cleaner, more advanced societies were getting sicker with allergies led to one of the most famous concepts in modern immunology.
Formulated in 1989 by David Strachan, it is known as the hygiene hypothesis.
Let's dig into the hygiene hypothesis. The initial observation wasn't even about biology labs, it was about family size, wasn't it?
It was a brilliantly simple epidemiological observation. Researchers looked at large families and noticed a stark pattern.
What did they see?
The oldest children in these families, the firstborns, who typically receive the most intense parental focus regarding strict hygiene, the sterilization of pacifiers, the absolute isolation from dirt, had significantly higher rates of hay fever and eczema.
And the younger ones.
Conversely, the youngest children, the fourth or fifth siblings, who were constantly exposed to the dirt, the germs, and the endless respiratory infections brought home by their older siblings, they had remarkably lower rates of allergies.
So the implication is that early childhood dirt and illness were actually protective.
Exposure was protective. You have to consider the evolutionary context. The human immune system evolved over millions of years in an environment teeming with constant environmental antigens.
And crucially, massive burdens of parasitic infections, specifically helminths or parasitic worms.
Exactly. The entire Th2, IgE, mast cell, and eosinophil pathway did not evolve to make you sneeze during spring.
It is a highly specialized weapon system, evolved specifically to fight off multicellular parasites.
Eosinophils are uniquely equipped to swarm a parasitic worm and dump tissue-melting proteins onto its skin.
But in modern, industrialized, highly sanitized environments with clean water and deworming medications, we have largely eradicated parasitic infections in children.
Which leaves the Th2 system completely unemployed. And an unemployed, highly armed immune system is a bored, hypervigilant immune system.
So without the constant low-level stimulation of harmless soil microbes and the occasional parasite to keep the Th2 pathway occupied, it just goes rogue.
It fundamentally misidentifies harmless targets. It points its anti-parasite weapons at dust mites, pet dander, and tree pollen.
The modern composition of our intestinal microbiome, altered by processed foods and antibiotics, plays a massive role here, right?
It does. It fails to provide this early life immune calibration.
It makes a terrifying kind of sense. The defense network is built for a war that never comes, so it starts shooting at shadows. Is this the only explanation, or do immunologists have a competing theory?
Science never settles on just one theory. Professor Coutinho details a critical refinement of this idea called the counter-regulatory hypothesis.
What is that one about?
This hypothesis is less about the Th2 system being bored and more about a fundamental failure of the immune system's braking mechanism.
The brakes.
Yes. Our immune system possesses a dedicated peacekeeping force called regulatory T cells, or TREGs.
Their entire job is to act as the adults in the room, right?
Exactly.
Yeah.
Suppressing both aggressive Th1 and Th2 responses when they aren't needed, preventing collateral tissue damage.
And how do they do that?
They achieve this suppression by releasing highly calming anti-inflammatory cytokines, specifically interleukin-10 or IL-10, and transforming growth factor beta, or TGF-beta.
So IL-10 and TGF-beta are the molecular stand-down orders.
Yes. The counter-regulatory hypothesis suggests that our modern lack of exposure to a diverse microbial environment in early childhood fails to induce a robust, mature, well-populated army of TREGs.
Without enough TREGs producing adequate levels of IL-10 and TGF-beta, the Th2 pathway operates without its natural brakes.
It encounters a pollen grain, accelerates into a full inflammatory response, and there's no chemical signal to tell it to stop.
Let's anchor all of this theory into the real world. When this unbraked system goes off in a patient, what does it physically look like in the clinic?
The clinical presentation depends entirely on the anatomical location where the mast cells are degranulating.
Okay, so if the allergen is inhaled and activates mast cells in the nasal mucosa.
The resulting local edema, vascular leakage, and eosinophil-rich discharge manifest as allergic rhinitis or severe hay fever.
But if that same allergen makes it further down into the lungs?
Then the activation happens in the lower respiratory tract. This is where those late-phase leukotrienes we discussed cause intense, smooth muscle contraction. This is asthma.
And Professor Coutinho makes a very specific, crucial clinical note here that runs counter to what most people intuitively assume about an asthma attack.
She does. When you watch someone having a severe asthma attack, they are gasping. It looks like they are desperately trying to pull air in.
Yet physiological reality is exactly the opposite, isn't it?
It is. The severe narrowing of the bronchioles, combined with thick mucus plugging, acts like a one-way valve.
So it is relatively easy for the strong diaphragm muscle to pull air in.
But it becomes incredibly difficult for the passive recoil of the lungs to push that air OUT through the narrowed pipes.
Asthma is characterized by expiratory difficulty, not inspiratory. You hear the wheeze on the exhale.
The lungs actually hyperinflate because air is trapped inside them.
Wow. And what happens if the allergen doesn't just hit a local surface, but gets directly into the bloodstream, say, a bee sting or a peanut protein absorbed through the gut?
That is the nightmare scenario. If the allergen enters the systemic circulation, it can cross-link IgE and trigger mast cell degranulation simultaneously across the entire body.
The massive systemic release of histamine causes a catastrophic sudden drop in blood pressure.
Because all the blood vessels dilate at once, and it's combined with rapid swelling of the airway. This is systemic anaphylaxis.
And without immediate epinephrine to force the blood vessels to constrict and the airways to open, it is rapidly fatal.
It is.
Given the stakes, how do doctors figure out exactly which microscopic protein the immune system has decided is the enemy?
The gold standard for in vivo diagnosis remains the skin prick test. It's a direct visualization of the mechanism we've been discussing.
How does it work?
The allergist introduces a microscopic amount of highly purified suspected allergen just under the top layer of the skin on the patient's back or arm.
If the patient has specific IgE bound to mast cells residing in that patch of skin, local cross-linking and degranulation occur almost immediately.
Within 15 minutes, the doctor observes a classic wheel and flare reaction.
What does that look like?
The wheel is a raised, pale, fluid-filled bump caused directly by the vascular leakage from histamine.
And the flare.
The flare is the wide red ring surrounding it, caused by the vasodilation of local capillaries.
We can also use blood tests, right? Like the RAST or specific Ig ELISA tests?
Yes, to measure the exact concentration of free-floating allergen-specific IgE in the serum.
Once we identify the target, how do we treat it? Let's walk through the step-by-step treatments, starting with the one that actually attempts to fix the root biological error. Desensitization.
Desensitization, or allergen immunotherapy, is the closest thing modern medicine has to a true cure for type I allergies. It relies on a brilliant manipulation of the immune system.
The patient is injected with progressive, carefully controlled doses of the specific allergen over a period of months or even years.
Wait, if they are severely allergic to it, why are we injecting them with it? Doesn't that risk anaphylaxis?
It does, which is why it's done in a clinic. But the goal is to systematically retrain the immune system.
By introducing the allergen via a different route, subcutaneous injection, instead of mucosal inhalation, and in specific escalating doses, we are attempting to force a massive cellular paradigm shift.
We want to exhaust the Th2 cells, stimulate the production of Th1 cells, and critically induce those calming tregs.
If the therapy is successful, the B cells receive new instructions. They undergo class switching again.
They stop making the explosive IgE and start making a different antibody class entirely, IgG.
And IgG does not bind to the Fc epsilon Ri receptors on mast cells.
Exactly. IgG simply floats freely in the bloodstream and interstitial fluid. It acts as a blocking antibody.
So when the fully desensitized patient encounters the pollen in the real world, the massive army of new IgG antibodies binds up all the pollen proteins before they can ever reach the IgE sitting on the mast cells.
It intercepts the keys before they ever get near the submarine. The mast cell never sees the allergen and the reaction is completely prevented.
That is an elegant biological hack. But desensitization takes years. What about immediate pharmacological treatments for someone suffering right now?
We have several tiers of intervention. The most ubiquitous are antihistamines.
These are straightforward receptor antagonists. They do not stop the mast cell from exploding. The histamine is still dumped into the tissue.
But the antihistamine drug rushes to the local blood vessels and physically plugs up the histamine receptors, blocking the histamine from binding and causing the vessels to leak.
They simply lock the door to the target tissue.
What if the reaction is more severe, like an asthma exacerbation?
Then we escalate to corticosteroids. Corticosteroids are heavy artillery. They don't just block a receptor on a blood vessel.
They physically enter the nucleus of immune cells and alter their gene transcription, right?
Yes. They are powerful, broad-spectrum anti-inflammatories that specifically inhibit the synthesis of the exact cytokines that drive the Th2 class switch. and they shut down the production of the late-phase lipid mediators like leukotrienes.
They pull the plug on the entire cytokine storm.
And the source material also mentions a very modern, incredibly sophisticated biologic drug called omalizumab.
How does this fit into the picture?
Omalizumab represents a triumph of modern bioengineering. It is a monoclonal antibody therapy. Essentially, scientists engineered an artificial antibody that attacks the patient's own antibodies.
Wait, really?
Yeah. Omalizumab is designed to bind specifically to the FEC region of free-floating human IgE in the bloodstream.
Hold on, the FEC region, that's the tail of the IgE. That's the exact same spot the IgE uses to dock into the receptor on the mast cell.
You've hit the exact mechanism of action. Omalizumab acts as a molecular cap. It covers the tail of the IgE antibody while it's still floating freely in the blood.
By capping the tail, it physically prevents the IgE from ever docking onto the Fc epsilon Ri receptor on the mast cell.
The mast cells are never armed, the trap is never set, and the type I allergy is neutralized at its most fundamental level.
Okay, to briefly synthesize Module 2. The context of type I involves genetic susceptibility on chromosomes 5 and 11, exacerbated by environmental factors like the hygiene hypothesis. And management ranges from antihistamines to omalizumab to full desensitization.
And that crucial transition from the chaotic, explosive IgE to the protective, blocking IgG provides the perfect conceptual bridge to our next major topic.
Because while IgG can be the celebrated hero that cures a type I allergy, when we move into our next section, IgG becomes the primary villain of the story.
I'm deeply intrigued by a villain origin story. Let's explicitly announce this shift. Module 3. Type 2 hypersensitivity, which Professor Coutinho also refers to as cytotoxic hypersensitivity.
We are leaving the world of IgE, allergies, and mast cells completely behind.
Type 2 hypersensitivity is driven almost exclusively by the antibodies IgG and, to a lesser extent, the large first responder IgM.
The core defining feature of a type 2 reaction, the absolute cardinal rule you must remember to differentiate it from everything else, is the physical location of the antigen.
In type 2, the antigen is permanently fixed directly to the surface of a specific cell in the body.
It's like a bright red target painted directly onto the wall of a very specific house.
Precisely. The immune system, for various reasons, produces high-affinity IgG or IgM antibodies that recognize that specific target on the cell surface.
They bind directly to the cell membrane, marking that specific cell for imminent, violent destruction.
But why would the body paint a target on its own cells? Is this just an autoimmune glitch?
It can absolutely be a spontaneous autoimmune mistake, but Professor Coutinho highlights a fascinating, externally driven pharmacological trigger: the concept of haptens.
Walk me through what a hapten is.
A hapten is a molecule, often a pharmaceutical drug, that is so incredibly small that it is completely invisible to the immune system on its own. It cannot trigger an immune response.
The source material specifically lists several notorious haptens. Penicillin, the common antibiotic, quinidine, a medication used to treat cardiac arrhythmias, and methyldopa, an older drug used for high blood pressure.
If they're invisible to the immune system, how do they trigger a massive cytotoxic hypersensitivity?
Because under certain chemical conditions, as they circulate in the bloodstream, these tiny drug molecules covalently bind to the surface proteins of circulating host cells, most commonly red blood cells or platelets.
The drug acts as a hapten. It chemically modifies the normal, healthy cell surface protein.
It changes the shape of the house.
It creates a modified self-protein. The immune system's surveillance cells come along, inspect the red blood cell, and determine, I recognize the overall shape of this cell, but what is this weird foreign penicillin molecule permanently glued to it?
The body loses tolerance. It mounts a massive immune response, producing billions of IgG antibodies directed specifically against the drug-coated cells.
Okay, so the red blood cell is circulating, covered in penicillin, and now it gets coated in IgG antibodies. The cell is marked for death. But antibodies don't actually kill cells on their own, do they? They just tag them.
Correct. Antibodies are just the targeting laser. They rely on downstream effector mechanisms to pull the trigger. If a cell is marked for death by IgG, the body utilizes two primary execution pathways.
Let's break those down. In my mind, if a cell is marked for death, the body has two execution methods. One is like a specialized demolition crew planting explosives directly on the walls of the house.
And the other is calling in a massive biological garbage truck to swallow the house whole. Walk us through Pathway 1, the demolition crew.
Pathway 1 is complement activation. When IgG or IgM tightly binds to the surface of the target cell, the physical shape of the antibody's tail, the FSC region, changes conformation.
This structural change acts as a highly attractive docking site for the first protein in the classical complement cascade, a protein called C1q.
The first domino falls.
And it triggers a rapid, sequential activation of dozens of complement proteins directly on the surface of the cell.
C1 activates C4 and C2, which activates C3, which activates C5, and so on.
The final fatal step of this cascade is the assembly of the membrane attack complex, universally known as the MAC.
The explosives on the wall.
Yes, the MAC is literally a microscopic ring of proteins that assembles itself and acts like a drill, punching a lethal open pore straight through the target cell's lipid membrane.
The integrity of the cell is destroyed. Water rushes in due to osmotic pressure, essential ions rush out, and the cell violently swells and ruptures. It lyses.
Complete targeted demolition.
Brutal and highly effective. And what about pathway 2, the garbage truck?
Pathway 2 is opsonization and phagocytosis. The word opsonization comes from a Greek term that roughly translates to preparing for the table or making tasty.
The target cell is heavily coated, opsonized with those IgG antibodies, and often with early complement proteins like C3b that deposited before the MAC could fully form.
The cell is covered in these warning flags. What happens as it circulates?
As these opsonized red blood cells or platelets circulate through the body, they eventually pass through the dense, highly filtered capillary networks of the reticuloendothelial system.
Primarily located in the spleen and the liver.
Right. Waiting in the microscopic cords of the spleen are massive, voracious, white blood cells called splenic macrophages.
The garbage trucks.
Crucially, these macrophages have dedicated receptors on their surface that specifically recognize and bind with high affinity to the FDC region of IgG, and separate receptors that bind to the C3b complement proteins.
They see the handles on the target cell and they grab on.
They grab the handles. The macrophage firmly binds to the coated red blood cell, physically drags it in, engulfs it entirely within a vesicle, and dumps powerful acids and digestive enzymes onto it.
The target cell is completely consumed and broken down into basic amino acids. The garbage truck swallows the house whole.
Whether it's the MOC drill or the macrophage garbage truck, the clinical result of this targeted destruction must be devastating.
The clinical presentation is a direct result of a catastrophic drop in the population of whatever specific cell type is being targeted.
So if the hapten, like penicillin, coats the red blood cells, the result is drug-induced hemolytic anemia.
The patient becomes severely anemic, profoundly fatigued, and often jaundiced as the ruptured red blood cells spill their bilirubin contents into the blood.
If the drug coats the platelets, the result is thrombocytopenia. Platelets are absolutely necessary for normal blood clotting, so the patient presents with unexplained bruising, petechiae on the skin, and dangerous internal bleeding.
The source material also details a very specific, tragic, and historically vital example of a type 2 reaction that doesn't involve pharmaceutical drugs at all, but rather blood types.
Let's dive deep into hemolytic disease of the newborn. How does this devastating condition perfectly illustrate the type 2 mechanism?
This is the classic textbook example of type 2 cytotoxic destruction, and it centers on the Rh blood group system.
The Rh factor is simply a protein antigen that is either naturally present, making you Rh positive, or genetically absent, making you Rh negative on the surface of your red blood cells.
So it's just another architectural feature on the house.
Exactly. The pathology occurs when an Rh negative mother is pregnant with an Rh positive fetus. The baby inherited the Rh gene from the father.
During her first pregnancy, everything is usually perfectly fine because the maternal blood supply and the fetal blood supply are physically separated by the placental barrier.
The mother's immune system has no idea the baby has different blood.
However, during the physical trauma of delivery, or sometimes during a miscarriage or an amniocentesis, there is inevitably a mixing of blood. A small volume of the baby's Rh-positive red blood cells enters the mother's circulation.
The mother's immune system encounters these cells and says, I have never seen this Rh protein before in my life. This is a foreign invader.
So she mounts a primary immune response.
She becomes sensitized. Over the next few weeks, her B cells produce robust amounts of IgG antibodies specifically designed to target and destroy any cell carrying the Rh antigen.
Now, this doesn't affect the first baby because the baby has already been safely born.
But the mother is now permanently armed. She has memory B cells waiting.
Yes. The profound danger arises during a subsequent pregnancy. If she becomes pregnant with a second Rh-positive fetus, Even a tiny amount of fetal antigen crossing the placenta will wake up those memory B cells.
They rapidly pump out massive amounts of highly targeted anti-RH IgG. And here is the critical physiological detail that causes the tragedy. IgG is the only class of antibody physically capable of crossing the placenta from mother to child.
Because the body designed IgG to cross the placenta to protect the baby from infections.
Yeah.
But here, the protective mechanism becomes a weapon.
The mother's anti-RH IgG crosses the placenta, enters the fetal circulation, binds directly to the fetal red blood cells, and initiates the exact type 2 destruction pathways we just discussed. Massive MSC lysis and widespread macrophage consumption in the fetal spleen.
The fetus develops profound hemolytic disease, leading to severe, life-threatening anemia, overwhelming heart failure, massive edema, and often death in utero or shortly after birth, unless extreme medical intervention occurs.
It's heartbreaking. But we don't see this nearly as often today, right? Modern medicine figured out a way to intercept it.
It is truly one of the great triumphs of modern preventative immunology. Today, we routinely administer a prophylactic injection called RhoGAM to Rh-negative mothers during pregnancy and immediately after delivery.
RhoGAM is simply a dose of commercially prepared anti-Rh antibodies.
Wait, we inject her with the very antibodies we are trying to prevent her from making. How does that help?
It's a race. The injected RhoGAM antibodies immediately find any stray fetal Rh-positive cells that leaked into the mother's blood and bind to them.
They physically cover up or mask the Rh antigen.
Because the antigen is hidden, the mother's own immune system never sees it, never reacts to it, and never forms her own permanent memory B cells. We clear the fetal cells before she can become sensitized.
That is an unbelievable application of immunological mechanics to save lives.
So, to quickly synthesize Module 3. Type 2 hypersensitivity involves IgG or IgM antibodies targeting an antigen that is physically fixed to a cell surface. The destruction is highly precise, localized entirely to that specific cell type, and is mediated by complement MAC explosives or macrophage garbage trucks.
An excellent synthesis. Which brings us to the next logical question in our progression, previewing our next module. We've seen the devastation that occurs when antibodies target a fixed stationary cell. But what happens when the antigens aren't attached to a cell at all?
What if the targets are just thousands of free-floating proteins dissolved in the bloodstream?
That sounds incredibly messy, like trying to shoot a swarm of gnats.
Let's find out how the body handles it. I'll explicitly announce the next section.
Module 4. Type 3 hypersensitivity, historically known as immune complex disease.
Messy is the perfect word for it. If type 2 is a highly targeted sniper strike against a specific painted cell, type 3 is collateral damage on a massive systemic scale. The initial mechanism starts out looking very similar. The immune system produces heavy amounts of IgG antibodies.
But in type 3, these IgG antibodies are directed against soluble antigens, proteins that are freely dissolved and circulating in the blood plasma or tissue fluid, rather than fixed to a membrane.
So the IgG antibodies are just swimming through the blood, grabbing onto these floating proteins wherever they bump into them.
Yes, and because every IgG molecule has two identical binding arms, it's shaped like a Y, and these freely floating antigens often have multiple binding sites on their surface, they start clumping together.
One antibody grabs two separate antigens, another antibody grabs the other side of those antigens.
And soon you have a massive three-dimensional microscopic lattice floating in the bloodstream. This lattice structure of cross-linked antibodies and antigens is called an immune complex.
Now hold on. Surely immune complexes form all the time. If I get a viral infection, my antibodies bind to the soluble viral proteins floating in my blood.
Right.
How does a healthy body get rid of these complexes without causing a hypersensitivity disease?
You're absolutely right. They form constantly during normal immune responses, and the body has a highly efficient waste disposal system for them.
Under normal, healthy circumstances, the early proteins of the complement system, specifically C2 and C4, bind to the outer edges of these floating immune complexes.
This complement coating does two vital things. First, it prevents the complexes from clumping together into massive, insoluble boulders. It keeps them small and dissolved.
Second, it allows the complex to physically hitch a ride on circulating red blood cells.
The red blood cells act like a transit system for the garbage.
Exactly. The red blood cells have a specific receptor called CR1 that grabs the complement-coated immune complex. The red blood cell safely ferries the complex through the circulation directly to the spleen or the liver.
As the red blood cell squeezes through the tight capillaries of the spleen, those voracious splenic macrophages gently pluck the immune complex off the red blood cell, ingest it, and destroy it, letting the red blood cell continue on its way unharmed.
It's an elegant, silent clearance mechanism.
So where does the pathology of type 3 begin? How does this elegant system break down?
The pathology occurs entirely due to an imbalance of scale. Type 3 disease happens when the production of immune complexes vastly exceeds the system's clearance rate.
The immune system is pumping out too much IgG, and there is simply too much antigen. The transit system gets overwhelmed.
Without enough complement to keep them small, the complexes grow massive. They lose their solubility, they become heavy, and they literally precipitate out of the blood fluid.
I promised a plumbing analogy for this earlier, and this is where it fits perfectly to visualize this mechanical failure.
Think of the human bloodstream as a massive, intricate plumbing system. Normal, efficiently cleared immune complexes are like fine dust. The water carries it easily, and the filter traps it without a problem.
But type 3 complexes, when production runs rampant and they clump together, are like throwing handfuls of wet gravel down the drain.
The flow of water simply can't carry it. So what does gravel do? It sinks to the bottom, it settles into the microscopic low-pressure pipes of our capillaries, completely clogging the delicate endothelial lining of our blood vessels.
That is precisely the mechanical reality of what happens. The technical clinical term is endothelial deposition. These massive, heavy immune complexes drop out of circulation and physically embed themselves into the walls of blood vessels.
Most often in areas where blood is highly filtered under pressure, like the glomeruli of the kidneys, the synovial membranes of the joints, and the capillary beds of the skin.
And this is where the disaster truly begins, because these deposited complexes act as a massive, localized inflammatory trigger.
Because they're packed full of IgG tails, which we know from type 2 triggers the complement cascade.
Exactly. The IgG triggers the classical complement cascade, but this time, the explosive MC isn't happening on a target cell. It's happening directly against the delicate wall of your own blood vessels.
This localized, intense complement activation releases huge amounts of the potent anaphylatotoxins we discussed in Module 1, C3A, C4A, and C5A.
Well, remember what those do. They act as direct chemical triggers that force local mast cells to degranulate, completely bypassing IgE.
Yes. The local mast cells explode, releasing histamine. The histamine causes local tissue edema and severe vasodilation. The blood vessel swells and becomes leaky.
Ironically, this makes the vessel even more porous, allowing even more immune complexes to get trapped in the expanding tissue. It's a devastating vicious cycle.
But the most destructive player in this entire cascade is the complement protein C5A.
Why C5A specifically?
Because C5A acts as a massive, irresistible chemical homing beacon for neutrophils. Neutrophils are the aggressive shock troops of the innate immune system.
They are incredibly violent cells, packed to the brim with highly toxic, tissue-melting digestive enzymes and reactive oxygen species.
They follow the C5A chemical trail, rush out of the bloodstream to the vessel wall, and find this massive, glowing immune complex embedded there.
So the neutrophils try to eat the immune complex, just like a macrophage would.
They try to phagocytose it, but they can't. The immune complex is physically permanently fused to the endothelial basement membrane of the blood vessel.
It's like a person trying to eat a stain that has been baked into a carpet. The neutrophil cannot ingest it.
It becomes highly activated, and in its violent failed attempt to digest the complex, it simply spews all of its toxic enzymes and bleach-like chemicals directly onto the blood vessel wall.
The scientific term for this is almost darkly poetic: frustrated phagocytosis.
That is the actual literal term in the literature. Frustrated phagocytosis. The result of thousands of neutrophils aggressively degranulating onto the vessel wall is severe, devastating structural damage.
The blood vessel undergoes a specific type of death called fibrinoid necrosis. The vessel breaks down, bleeds into the surrounding tissue, and completely loses its ability to function.
This is brutal, systemic collateral damage. Let's anchor this pathology to the specific clinical examples Professor Coutinho provided. She starts with a localized, experimental version called the Arthus reaction.
The Arthus reaction is primarily an experimental model, but it perfectly demonstrates the timeline and mechanism. Imagine an individual who has already been highly immunized against a specific antigen.
Meaning they have very high levels of circulating IgG ready to go.
If you suddenly inject a large, concentrated dose of that exact soluble antigen locally, right under the skin, massive immune complexes form immediately at that exact injection site within 1 to 2 hours.
Because the high concentration of IgG meets the high concentration of antigen all at once in a tiny physical space.
Right. The wet gravel forms instantly. The complexes deposit in the local skin capillaries, trigger massive complement activation, recruit swarms of neutrophils via C5a, and within a few hours you observe severe local edema, hemorrhage, and potentially dark, dead tissue necrosis right at the injection site.
But type 3 isn't usually just a spot on the arm. It can happen across the entire body at once.
Yes, and the classic foundational historical example of a systemic type 3 disease is serum sickness. To truly understand this, we have to look back to the medical realities of the pre-antibiotic era, specifically around 1906 when Clemens von Perke first described it.
Imagine a patient dying of severe pneumococcal pneumonia or diphtheria. Doctors had no antibiotics to kill the bacteria. Their only tool was passive immunity.
Explain passive immunity in this historical context.
Doctors would take horses, vaccinate them against the human bacteria, and wait for the horse to produce massive amounts of antibacterial antibodies.
Then they would draw the horse's blood, extract the serum, the fluid packed with horse antibodies, and inject massive volumes of this foreign horse serum directly into the dying human patient.
The horse antibodies would attack the bacteria and hopefully save the patient's life.
They would, and it was a miraculous, life-saving therapy. But there was a massive delayed cost. The human immune system suddenly realizes that there are billions of foreign horse proteins floating in its bloodstream.
However, it takes the human body about 7 to 10 days to mount a primary antibody response against a new antigen.
That's the sensitization window, the quiet period.
Exactly. For a week, the patient seems fine. But around days 7 to 10, the human's B cells suddenly start pumping out massive amounts of human IgG directed specifically against the horse proteins.
Because there is still a huge volume of horse protein floating in the blood, billions of immune complexes form simultaneously across the entire circulatory system. The red blood cell clearance system is instantly and completely overwhelmed.
It's throwing wet gravel into every single pipe in the house all at the same time.
Precisely. The complexes precipitate out and deposit in the capillary beds of the skin, causing severe, widespread urticarial rashes.
They deposit in the highly filtered synovial fluid of the joints, causing crippling, painful arthritis.
And most dangerously, they deposit in the delicate filtration capillaries of the kidneys, the glomeruli, causing acute glomerulonephritis, leading to blood in the urine and kidney failure. The patient spikes a high fever, gets severe chills, and suffers massive systemic inflammation.
Does it ever stop? Or is it fatal?
It is generally a self-limiting disease. The inflammation is horrific, but once the human immune system successfully clears every last molecule of the foreign horse protein, no new immune complexes can form.
The neutrophils eventually clear the necrotic debris, the vessels attempt to heal, and the patient usually recovers. Today, we obviously don't use horse serum for pneumonia, but we still see serum sickness occasionally.
It happens with anti-venom treatments for snake bites, which are often derived from sheep or horses, or with certain modern systemically infused monoclonal antibody therapies.
Okay, that is a heavy module. Let me quickly synthesize type 3. It is all about soluble antigens forming floating immune complexes with IgG. When the red blood cell clearance system fails, these complexes embed like gravel in blood vessel walls.
This activates complement, draws in aggressive neutrophils via C5a, and causes severe collateral tissue damage through frustrated phagocytosis and fibrinoid necrosis.
And it presents locally as Arthus reactions or systemically as serum sickness with its classic 7 to 10 day delay.
A very clear summary. And that brings us to the final frontier of our deep dive. We spent the better part of an hour detailing how antibodies, IgE causing immediate explosions, IgG acting as sniper fire, or Ig causing systemic complex crashes, orchestrate these disastrous overreactions.
But what if I told you there's an entire category of hypersensitivity where antibodies play absolutely zero role?
No antibodies at all. I think we are ready for the final piece of the puzzle. Let's explicitly announce this last section, Module 5, Type 5 hypersensitivity, which is also known as delayed or cell-mediated hypersensitivity.
This requires a massive paradigm shift in how we've been thinking. Types I, II, and III are all manifestations of humoral immunity, which is the branch of the immune system driven by the fluid components of the blood, specifically the antibodies produced by B cells.
Type 5 stands entirely, completely alone. It is strictly 100% mediated by physical cells, specifically T lymphocytes.
So B cells and their antibodies are completely benched for this one.
They are not involved. And because type 4 relies on the physical mobilization, division, and physical migration of actual cells through the tissues, rather than the rapid circulation of preformed antibodies in the blood, It takes much, much longer to manifest clinically.
That is why it is explicitly called delayed hypersensitivity. The clinical tissue response takes a minimum of 24 to 72 hours to fully develop after exposure.
So if I touch something I'm allergic to via type 4 mechanism, I literally won't know for 2 or 3 days. Let's walk through the mechanistic cascade. If there are no antibodies to trigger things, how does this T-cell reaction actually start?
It starts with a sensitization-like phase, often when an antigen physically penetrates the skin barrier into the subcutaneous tissue. Waiting there are local antigen-presenting cells.
In the skin, these are specifically called Langerhans cells, which are a type of dendritic cell, along with local tissue macrophages. They capture the penetrating antigen, process it internally, and present the peptide fragments on their outer surface.
But they use a very specific, highly important structural display molecule called MHC class II.
The major histocompatibility complex class II. We've talked about that as the immune system's display case.
Yes. They carry this MHC display case to the local draining lymph node. But they aren't looking for Th2 cells to make IgE like in type I.
In a type 4 reaction, they present the antigen to a completely different lineage of T cells, effector Th1 cells.
The Th1 cells recognize the antigen in the display case. What is their immediate response?
They activate, undergo rapid cellular division to form an army of clones, and physically migrate out of the lymph node. They travel through the bloodstream back to the specific peripheral site where the antigen was initially introduced.
Once they arrive at the site, they recognize the lingering antigen again, and they execute their primary function.
They release a very specific, overwhelmingly powerful cocktail of pro-inflammatory cytokines into the local tissue.
What are the specific cytokines in this Th1 cocktail? We know it's not the IL-4 and IL-5 of the mast cell storm.
The source material lists the crucial players for type 5, IFN gamma or interferon gamma, TNF-alpha, IL-8, IL-3, and GM-CSF.
What do these specific signals do to the local tissue?
They completely alter the microenvironment. TNF-alpha acts on the local vascular endothelium to make the blood vessel walls incredibly sticky, trapping circulating immune cells.
But the true powerhouse here is IFN gamma. IFN gamma is the ultimate master activator of macrophages.
It serves as a massive recruitment signal, drawing monocytes out of the blood and into the tissue, and then hyperactivating them. It turns normal, resting macrophages into hyperaggressive, tissue-destroying, highly phagocytic machines.
So instead of a fast histamine-driven fluid leak that causes an immediate hive, you get a slow, building, massive physical influx of angry cells literally crowding into the tissue space.
Exactly. The arriving macrophages and the recruited T cells cause severe localized inflammation. The tissue physically swells, not with fluid, but with the sheer mass of thousands of cells packing together.
This cellular crowding creates hard, raised, visible lesions called indurations.
Let's anchor this clinically, because the most famous application of this delayed mechanism is actually a diagnostic tool we use to our advantage in medicine, the tuberculin, or MANTU, test for tuberculosis.
How does the TB test hijack this type 5e hypersensitivity?
It's a brilliant, elegant application of cellular biology. We want to know if a patient has ever been infected with the bacteria, Mycobacterium tuberculosis.
So the doctor takes a harmless, highly purified protein extract of the bacteria called PTD, or purified protein derivative. It cannot cause the disease. They inject a tiny amount of it directly into the subcutaneous tissue of the patient's forearm.
And then the patient goes home, and we wait.
We wait precisely 48 to 72 hours. If the patient has never been exposed to TB in their life, nothing happens. The local macrophages quietly clear the harmless protein and the skin remains flat.
But if they've been exposed in the past, they possess a circulating army of memory Th1 cells that were specifically programmed years ago to recognize that exact TB protein.
So over those 2 or 3 days of waiting, those memory Th1 cells are migrating through the blood, finding the injection site, and setting up camp.
Yes. They recognize the PPD protein on the local APCs in the arm, they start blasting out IFN gamma and TNF-alpha, and they recruit a massive, localized army of activated macrophages to the injection site.
When the patient returns to the clinic on day 3, the doctor doesn't just look for a red rash. They physically run their finger over the arm, palpating the skin to feel for an induration, a hard, raised, palpable bump caused by the sheer physical volume of all those macrophages packed tightly into the dermal layer.
And the physical diameter of that hard bump proves T-cell memory.
Precisely. The clinician literally measures the diameter of the induration in millimeters. It is a visible, tactile, measurable manifestation of cell-mediated immunity in action.
That's fascinating. We use the delayed hypersensitivity as a diagnostic readout.
Yeah.
But type 4 isn't just used for tests. It causes everyday agonizing misery for millions of people.
How does allergic contact dermatitis fit into this cellular mechanism?
Allergic contact dermatitis is the classic pathological type 4V reaction. Poison ivy is the most famous natural example, but Professor Coutinho uses a very common, highly illustrative industrial example: nickel allergy.
A person wears a cheap belt buckle with nickel in it, or cheap jewelry. 3 days later, they have a blistering, weeping, incredibly itchy rash exactly mirroring the shape of the metal on their skin.
I always wondered about that. Nickel is an inorganic elemental metal. It's not a complex biological protein like pollen or a peanut. How can T cells, which are designed to hunt viruses and bacteria, react to a piece of metal?
Nickel acts as a hapten, employing the exact same conceptual mechanism we saw with penicillin in the bloodstream. But this time it happens directly in the epidermis.
As the metal touches the skin and mixes with sweat, microscopic nickel ions leach out. These ions penetrate the outer layer of the epidermis and chemically covalently bind to the host's own structural skin proteins.
It alters the body's own proteins right there at the contact site.
Yes, it creates a modified self-protein. The local Langerhans cells in the skin engulf these modified nickel-bound proteins, process them, and present them via MHC2 to Th1 cells in the draining lymph nodes.
The Th1 cells become activated, multiply, migrate back to the exact patch of skin where the metal is touching, release their cytokines, and orchestrate a massive macrophage attack on your own modified skin cells.
The macrophages destroy the epidermal layers, resulting in the delayed, blistering eczematous rash.
It's incredible how the immune system uses the same fundamental biological rules, but deploys them in such vastly different ways depending on the context.
That wraps up the heavy lifting of the cellular mechanisms. Now, to truly lock in this university-level material, we need to do a dedicated comparative reasoning section. Let's do some side-by-side contrast to make sure the boundaries between these complex mechanisms are crystal clear for you listening.
A vital exercise. When learning clinical immunology, understanding the boundaries and the distinctions is just as important as memorizing the individual pathways.
Let's start by contrasting type 2 and type 3, because they both involve the antibody IgG activating the complement cascade, which can be incredibly confusing when you first study it.
Right, IgG is the trigger that pulls the complement pin for both of them. So what is the defining, absolutely critical difference?
The physical location of the antigen. That's the only distinction you need to anchor onto. In type 2, the antigen is fixed to a cell surface. It is a target painted directly on a specific house.
The destruction is highly precise and localized entirely to that specific cell type, causing direct cytopenias like hemolytic anemia or thrombocytopenia.
Whereas in type 3,
In type 3, the antigen is soluble, floating freely in the fluid of the blood. The IgG binds to it in midair, so to speak, forming a floating immune complex.
the eventual destruction doesn't happen where the antigen originated. It happens wherever that massive complex happens to sink and get stuck in the plumbing. The vessels, the kidneys, the joints. Type 3 is a systemic disease of innocent bystander collateral damage.
Excellent distinction. Now let's contrast type I against types 2 and 3.
Type I is entirely unique in its sheer speed and its specialized weaponry. It is the only hypersensitivity that relies on the antibody immunoglobulin E, or IgE.
It is the only one that relies on the covert pre-arming of mast cells via that specific Fc epsilon Ri receptor. And it is the only one that results in immediate explosive degranulation upon re-exposure, causing symptoms in minutes.
Types 2 and 3 rely on the heavy lifters IgG and IgM, and they heavily utilize the slower complement system and phagocytic cells like neutrophils and macrophages to slowly destroy tissue over hours or days.
And finally, let's contrast the first three types 1, 2, and 3 against type 4.
This is the cleanest, most absolute divide in all of clinical immunology. Types 1, 2, and 3 are all antibody-mediated. They are fundamental failures of the humoral immune system.
Type 4 stands entirely apart. It is strictly, completely T-cell mediated. No antibodies are involved in the pathology.
It is a failure of cellular immunity, which accounts for its delayed 24 to 72-hour timeline, because it literally takes days for physical cells to migrate through the body and recruit other cells to form a physical inflammatory lesion.
Okay, to solidify these abstract concepts, I want to bring it back to real life, specifically the food we eat, because people use the word allergy very loosely in everyday conversation.
So what does this all mean for something like a wheat allergy?
Precision in language matters immensely here. A true wheat allergy is a classic type I hypersensitivity. The patient has been sensitized to a specific wheat protein.
They have IgE antibodies against wheat permanently bound to their mast cells. If they eat a piece of bread, they experience an immediate, potentially life-threatening Ig-mediated degranulation, causing hives, facial swelling, severe wheezing, or full systemic anaphylaxis within minutes of ingestion.
That is a true Ig-mediated allergy, but what if someone just gets a stomach ache?
That is fundamentally completely different from a non-immune intolerance. Take lactose intolerance, for example. That isn't an immune reaction at all. It's simply a mechanical enzymatic lack of the lactase enzyme in the gut.
The bacteria ferment the sugar, causing gas and pain. The immune system is completely oblivious to the entire process.
And it's also vastly different from celiac disease, right? Because people often confuse a wheat allergy with celiac.
They are biologically night and day. Celiac disease is an autoimmune condition driven by deeply complex cellular mechanisms involving T cells and different autoantibodies like anti-tissue transglutaminase reacting to the gluten protein in wheat.
It causes chronic, long-term inflammatory damage to the villi of the small intestine, leading to malabsorption over years, rather than the immediate explosive mast cell anaphylaxis of a type I allergy.
It is clinically crucial to separate true type I IgE allergies from mechanical intolerances and chronic autoimmunities.
What an incredible, exhaustive journey we've just taken. We have covered the sheer power, the stunning complexity, and the sometimes terrifying potential for self-destruction residing within our own bodies.
From the immediate histamine-soaked IgE explosions of mast cells in type 1 to the targeted complement-driven IgG sniper fire in type 2 to the systemic neutrophil-ravaged collateral damage of immune complexes in type 3 and finally the delayed cell-mediated march of angry macrophages in type 4.
It is a profoundly remarkable system, but as we've seen, it balances on a razor's edge of regulation.
You have essentially just completed a rigorous masterclass in clinical immunology. We hope you walk away seeing the human body not just as a static anatomical diagram, but as a fiercely active battlefield.
I want to leave you with a concluding philosophical thought regarding the immense amount of biology we've unpacked today.
Please do.
We spend so much of our time and billions of dollars in global medicine worrying almost exclusively about external pathogens, the invading viruses, the drug-resistant bacteria, the novel parasites.
Right, the outside threats.
But as we've seen by looking deeply at hypersensitivity, the line between absolute life-saving protection and catastrophic self-destruction is incredibly dangerously thin. The difference between health and disease is just a single misfiring cytokine, a lack of early microbial exposure in childhood, or an antibody binding to the slightly wrong target.
It really puts it into perspective.
The true mastery of medicine in the future won't just be finding new, more powerful ways to kill the invaders. The ultimate mastery will be learning how to negotiate a lasting, perfectly calibrated peace treaty with our own immune system.
A brilliant way to frame it. Think back to our opening metaphor. The medical X-ray machine looks for a broken bone, a clean, visible, easily identifiable structural failure.
But the diagnostic muddy waters of hypersensitivity reveal that our bodies are not just mechanical structures.
They are highly orchestrated, fiercely guarded, and sometimes chaotic symphonies of interacting cells. Understanding the why and the how behind that microscopic chaos is what makes the science of the human body so endlessly, terrifyingly fascinating. Thanks for sitting down with us and keep diving deep.